All right. Well, thank you all for joining today. We have a great presentation and conversation for folks. Um, we're going to talk today about what folks involved in youth justice really should know about Medicaid. And there are a number of reasons why this topic is important, even critical during this time. First, as we know, many youth involved with the justice system have significant needs, physical health needs, dental needs, mental health needs, trauma, and more, all of which can be addressed by a well-designed and well-integrated healthcare system. Second, at the start of this year, January 1, there was a substantial change to Medicaid policy requiring certain Medicaid services for incarcerated youth to prepare to prepare youth to reenter the community and to support them once they do. We hosted a webinar on that last fall, and if you didn't have a chance to see that, um, I believe it's still available on YouTube and through our Annie EKC website. Third, and in my opinion, most importantly, and as I know from personal experience from years of working in and leading child welfare, youth justice, and children's behavioral health care systems, many of the youth have these needs, particularly behavioral health care needs, met by providers through the youth justice system. Using the youth justice system in this way instead of a healthcare system in this way is not only poor fiscal practice for a jurisdiction, but it's not best for youth. And the reason for that is that when we turn the youth justice system into a physical or more commonly behavioral healthcare system, it becomes a magnet for youth who can't have their needs met through the broader healthcare system in the community. It results in youth remaining in the justice system longer than necessary in order to continue their treatment. And it means that once youth do leave the justice system, any therapeutic relationships that they've developed with providers are often severed when the payment structure for care reverts from the justice system back to the healthcare system. Instead, we can thoughtfully design our healthcare systems, particularly Medicaid, to provide care that is complementary to youth involved with the justice system, and in the process, have that serve as a prevention system to prevent involvement in the justice system, as well as meeting the needs of youth involved in the justice system and supporting them as they discharge back to the community. In order to start shifting the way the justice systems and healthcare systems work to center youth, folks in youth justice need to get much more comfortable understanding how Medicaid works and what is possible. That's what we hope to accomplish today with this webinar. Next slide, please. So we're going to cover the following topics here. We're going to talk about the role of Medicaid and the Children's Health Insurance Program in youth justice. We're going to talk about what's probably the most generous benefit, perhaps in all of healthcare for young people, and that is EPSDT, early and periodic screening, diagnostic, and treatment benefit. We're going to talk about what happens with Medicaid when youth are incarcerated, and then we're going to spend a little bit of time talking about how new federal policy, HR 1 or the budget bill that just passed, federal budget bill that just passed, might shift this landscape. Lastly, we'll do a Q&A. You'll see that the chat feature is not active for the webinar, but there is a Q&A function open. You can post questions in there, even in real time. No need to wait for the end. And we will address the questions directly in the Q&A feature or verbally during the Q&A session at the end. The webinar is scheduled to end at 3 p.m. Eastern Time, but we will remain on if we have lots of questions. We are recording the webinar so folks can review the material we cover later, but we will stop recording once the Q&A session starts. Next slide, please. So I am Joe Ripsum. I'm the Director of Child Welfare and Juvenile Justice Policy at the Annie Casey Foundation, and I'm joined today by three remarkable colleagues with the Center for Healthcare Strategies, who you'll hear from each at length: Alyssa Gelber, Jade Kissy, and Liz Buck. Next slide, please. And a little bit about the Annie E. Casey Foundation. We are a private philanthropy that builds a brighter future for the nation's children and youth. We want to make sure that all young people have the family connections, relationships, communities, and educational and employment opportunities that they need to thrive. We focus on children from birth through their mid-20s because research shows that young people are still growing and developing until then. We concentrate on young people and families with the greatest needs, including those who have low incomes, live in high poverty communities, and are involved in child welfare and justice systems. And we know that children and families of color often face the greatest barriers to success. Using data as our guide, We develop innovative ideas to address the challenges these young people and families face. We work with a diverse set of allies across political lines and across sectors to invest in the most effective strategies based on solid evidence, and we help them reach as many children and families as possible. We know what works. Sustainable solutions emerge when families and young people who have experienced the systems are deeply involved in designing the solutions. And now I'll hand this over to my colleague, Alyssa. And next slide, please.
Thank you so much, Joe, and thank you to the NEKC Foundation for putting this session together. So good to be with you all. My name is Alyssa Gelber from the Center for Healthcare Strategies. Our goal at CHCS is to strengthen the healthcare system by supporting states throughout the country in improved healthcare outcomes, particularly for individuals served by Medicaid. We have worked with all 50 states through technical assistance and implementation support. Next slide. And you go to the next one. So there is a critical connection between healthcare and justice system involvement, which is something that many of you see every day in your work. Unmet healthcare needs drive justice system involvement and also result from justice system involvement. And as the main payer of healthcare services for youth involved in the justice system, Medicaid really matters. Access to Medicaid has been shown to improve healthcare outcomes as well as decrease rates of recidivism and prevent deeper justice system involvement. Next slide. So Medicaid access is important at every point in the justice system continuum. We have spent a lot of time recently focused on the Consolidated Appropriation Act changes and states' ability to access Medicaid funding during incarceration. Many of you have joined prior discussions of those topics, as Joe mentioned in his opening. This is really important, and we will be touching on incarceration in a little while. But we really want to emphasize today the importance of Medicaid as a funding source for a broad array of services, from prevention to reentry, in both juvenile justice and child welfare, so across the entire continuum. When utilized properly, Medicaid and CHIP can help prevent deeper system involvement. So as you can see depicted here, Medicaid funding supports primary care, early intervention, crisis continuum, behavioral health and substance use treatment, in-home and out-of-home care, among other services for children, youth, and families. Next slide. So we're going to turn next to a discussion of the early and periodic screening, diagnostic, and treatment benefit, or EPSDT, through which children and youth access services in Medicaid. For this portion, I'm going to be joined by my colleague, Jade Kissy, to whom I will pass the mic now.
Thank you, Alyssa. So the early and periodic screening, diagnostic, and treatment is the mechanism through which children and youth access all needed healthcare services. All children under the age of 21 eligible for Medicaid are entitled to this benefit. EPSDT provides a comprehensive array of preventative, diagnostic, and treatment services for low-income infants, children, and adolescents under 21, specified under the Social Security Act. The EPSDT benefit is more robust than the Medicaid benefit for adults and is designed to assure that children receive early detection and care so that health problems can be averted or diagnosed and treated as early as possible. The goal of EPSDT is to assure that individual children get the health care that they need, when they need it, and the right care to the right child at the right time, in the right setting. Next slide, please. So as I mentioned, children are entitled to early periodic screening, diagnostic, and treatment under this benefit. Screening under this benefit is comprehensive and well-defined under Medicaid to mean more than what it typically means colloquially. And there are some examples on the screen of what this screening means. Go to the next slide.
So under Medicaid law, Section 1905A specifically, there are required and optional services for states which are reflected in each state's Medicaid state plan. Under Under EPSDT, importantly, states cannot choose what to offer to children and youth. Children and youth are entitled to all 1905A services that are deemed to be medically necessary. And it's really important to note that medical necessity is defined under the statute in a different way than under many commercial plans, to include, as you see here, anything needed, any services needed to correct or ameliorate a condition. As my colleague Liz Buck will discuss later in this session, this really important benefit remains intact in the wake of the budget reconciliation. Next slide. Thank you. So having zoomed out to discuss the role of Medicaid across the continuum of involvement in juvenile justice and the role of the EPSDT benefit more broadly, we are now going to zoom in a little bit to specifically discuss what happens when youth are incarcerated. And for that, I will turn things over to Liz Buck.
Thank you, Alyssa. As Alyssa shared, I'm Liz Buck and I work at Center for Health Strategies. For the next few slides, I hope to shed some policy context of when a youth is incarcerated, how that relates to the scope of benefits under Medicaid. And as Alyssa shared earlier in the flow chart of when a youth may be involved in the justice system, the goal of this section is also to talk about how Medicaid can play a role in furthering involvement. And for these portion of slides, I'll be talking about the point of incarceration and reentry. So when incarcerated, there are key changes in eligibility status and reimbursement for youth who are otherwise eligible for Medicaid and CHIP. Under the inmate exclusion policy, states have not been able to utilize Medicaid funding to pay for healthcare services for youth and individuals during incarceration. Children are also ineligible for CHIP when incarcerated. And as Alyssa sort of signaled earlier in the presentation, the Consolidated Appropriations Act of 2023 really sets up an exception to the Medicaid exclusion policy and CHIP eligibility exclusions, which we'll talk about in some more detail. Next slide. So you all may be working towards implementation and doing this in your communities, but I want to describe really these new changes under the CAA. So as I shared, there is a partial amendment of the inmate exclusion policy through the CAA. As of January 1, 2025, all youth, which is inclusive of Medicaid eligible youth under 21, CHIP eligible youth under 19, for foster care youth under 26, in all correctional settings, so GJ facilities, jails, prisons, tribal facilities, are required to have a screening and assessment, as well as targeted case management youth who are incarcerated and post-adjudicated. As you can see, this isn't a full turning back on the EPSDT during this time. It's sort of the SD of the EPSDT, but it really represents a significant opportunity to address unmet health needs by connecting youth to care in the community and really interrupting recidivism back to the justice system.
Pardon, Liz, there are people who are having trouble hearing you. I'm wondering if either you could move a microphone closer or...
oh, I'm so sorry. Is this better?
It is better.
Apologies. Should I go back a little bit, Carol?
Yes, Dianisa, if you could go to the previous slide, I think people should hear. And I think you should start from here, please.
Oh, I'm so sorry. Happy to. I'm sharing a little bit more here in the context of when a youth is incarcerated and how that relates to the scope of benefits under Medicaid. So Alyssa shared a little bit more about the flow chart of when a youth might be incarcerated. And for the purpose of this discussion, I'm really focusing on that access point of when someone is incarcerated and within the reentry process. So there are key changes in eligibility status and reimbursement for youth who are otherwise eligible for Medicaid and CHIP when incarcerated. Under the inmate exclusion policy, states who may not have been able to utilize Medicaid funding to pay for healthcare services for individuals during incarceration, as well as children, are also ineligible for CHIP when incarcerated. So key areas of access and reimbursement issues when individuals are incarcerated, or youth that are incarcerated. The Consolidated Appropriations Act of 2023, as Alyssa shared, sets up an exception to the Medicaid exclusion policy and these CHIP eligibility exclusions. Next slide. So these CAA requirements, which you may be involved in your communities and implementing right now, partially amends the inmate exclusion policy. As of January 1, 2025, all youth, Medicaid eligible youth under 21, eligible CHIP youth under 19, former foster care youth under 26, in all correctional settings, so JJ facilities, jails, prisons, and tribal settings, are required to have screening and assessment, as well as targeted case management. And this applies to youth who are incarcerated and are post-adjudicated. This really covers the SD part of screening and diagnostic within EPSDT. And while it's not inclusive of the full benefit when someone is incarcerated, it does represent a really important opportunity to interrupt recidivism and support youth in connecting to healthcare in the community. And some states are pursuing a portion of the CAA, which is optional, which would provide the full scope of services under EPSDT and full range of Medicaid and CHIP benefits services for all youth who beyond just adjudicated youth. I'll next turn to my colleague Jade, who will describe the targeted case management portion within this new requirement. Next slide.
So as Liz mentioned, targeted case management is an important requirement of the CAA, and its importance cannot be overstated in connecting youth to a full range of services needed to address their health needs that may have underlying causes or resulting from their justice system involvement. Targeted case management is much more than your typical case management. There are 4 discrete components, including assessment of need for medical and other services, development of and updates to an individualized and person-centered care plan, referral and service linkage to services and supports for behavioral health and other health-related social needs, and then ongoing monitoring and follow-up activities. There are other examples on the slide of what some of these health-related social needs can look like. And I will pass it back to Liz to talk about some of the federal implications. Next slide, please.
Thanks, Jade. So as we shared in the beginning, we recognize that there are new policy changes that are impacting how Medicaid is delivered. So we want to touch on that
Pardon me, Liz, once again, you're breaking up. Is there a way to move your microphone closer?
Is this any better?
Yes.
So sorry. Okay, next slide. So we wanted to give some analysis as it relates to the potential implications with new legislation, so the Budget Reconciliation Bill, or HR 1. As also shared, HR 1 does not explicitly impact EPSDT or the CAA 2023 provisions. our analysis in reading the bill and trying to understand the bill is that there may be youth impacted through the redetermination process. So some youth who may be eligible as a Medicaid expansion population may be subject to doing a redetermination every 6 months, which will now be required for certain populations with the legislation. I think good news or news that's supportive of this population. Certain populations will be exempt from requirements, which is part of the legislation. So that includes former foster care children up to age 26, individuals incarcerated in the preceding 90 days, so that pre-release and post-release period, individuals with substance use disorder, and the medically fragile. So that's what we know within the reading of the legislation and understanding of the legislation. There are some aspects of the legislation, it's to be determined. So there'll be further guidance from HHS related to redetermination and work requirements, and that's forthcoming. So that's within January and June 2026. So be looking out for that. And then we also know this is a period of time for your states to be considering and understanding the impact of the legislation. So there'll be a lot of thinking, I imagine, with stakeholders in your states to understand the downstream impacts of the legislation and how it will affect coverage and implementation moving forward. So with that, we have a lot of time for questions. So I'll turn to my colleague, Joe Ribson, for that period of the discussion.